The nose needs more than skin cover. A good reconstruction protects contour, support, lining, nostril position, and the airway. This explainer was written and edited by Dr. Thomas Hocker, a triple board-certified, Harvard and Mayo Clinic-trained dermatologist, Mohs surgeon, and dermatopathologist. So, let's get right into this fascinating architectural process.
When we think about treating a skin cancer on the face, the immediate natural thought is often just about closing up the surface opening. But a nozzle repair? Well, that must carefully replace missing tissue layers while actively protecting the overall shape and the airway beneath it. You see, covering the surface is really only part of the job. We have to think of this as a precision structural engineering project.
Today's agenda covers the architectural challenge, blueprinting the final wound, the reconstructive toolkit, building structural support, and finally, realistic outcomes and next steps.
Section 1. The Architectural Challenge. Because the nose is this incredible, three-dimensional sculpture made of skin, soft tissue, cartilage, and internal lining, we constantly have to consider what we call free margins. Basically, these are unanchored edges, just like your nostril rims. Now, because the nasal framework actually holds your airway open, any repair we do has to be precisely engineered. If the healing tissue contracts too much, which, by the way, might be completely harmless on a flat area like your cheek or forehead, it can pull heavily on those delicate free margins. That can cause visible distortion, notching, or even compromise your breathing. We have to meticulously design around these exact forces.
Section 2. Blueprinting the final wound.
This required level of architectural precision is exactly why any preoperative plan you discuss is really just a decision tree. The definitive blueprint can literally only be drawn after Mohs surgery achieves complete cancer clearance. The final wound reveals critical structural realities that photographs just simply cannot answer. The surgeon has to assess the exact wound depth, figure out which specific nasal subunits are involved, and see whether cartilage or internal lining is actually missing. They evaluate if the nostril rim is threatened by airway contraction risk, and they check the mobility of the nearby skin. This real-time blueprinting is what allows the surgeon to choose the absolute safest, most effective reconstructive path, committing tissue only when the true boundaries are completely known.
Section 3. The Reconstructive Toolkit.
Once that definitive blueprint is clear, the surgeon essentially opens up the reconstructive toolkit to select the ideal method for restoring cover, contour, and support. And here's the thing, there's no single universally superior repair. The options range from natural healing, which is also known as second intention, and linear tailoring, all the way up to custom inlays and stage tissue bridges. Each tool comes with its own distinct structural trade-offs. For example, an option that beautifully solves a shallow contour defect might fail completely if it's used near a delicate, unsupported nostril rim.
Let's look a little closer at straight line closure, which we can really think of as the art of tailoring. A straight line can be an incredibly elegant solution when nasal skin moves naturally without excessive tension. But this tailoring must be evaluated from every single angle. A closure that looks perfectly acceptable straight on from the front can still inadvertently flatten the nasal contour or lift the nostril when viewed from below. When we're utilizing our more complex tools, we have to carefully weigh local flaps against skin grafts. Now, while a local flap acts as a tissue bridge that brings nearby skin with a highly matched color and texture, it is absolutely not automatically the best repair. Sometimes, moving that nearby tissue would actually distort the surrounding anatomy. In those specific scenarios, a skin graft, acting as a custom inlay, can beautifully cover a broad, shallow wound without pulling on adjacent structures at all, though you do have to remember it brings different color, thickness, and contraction trade-offs.
Clinical evidence plays a massive role in how these materials are applied. For instance, in a comparative study of selected nasal tip and ala wounds, delaying a full thickness graft for 12 to 14 days actually reduced partial graft loss from 30% all the way down to 11%. This really demonstrates how strategic delays can sometimes prepare the wound bed for a much better outcome, though it is super important to remember that this represents a clinical pattern in a selected group rather than a rigid rule for every single graft.
And sometimes, the most sophisticated tool is just relying on nature itself. In some cases, the nose can heal beautifully without stitches. Again, a process called second intention. Modern outcome studies suggest this works best for small wounds that go no deeper than superficial fat. It requires a favorable location where tissue contraction won't warp the final shape or distort a free margin, provided that the critical structural support remains entirely intact underneath.
Section 4. Building Structural Support.
When the foundation of the nose is compromised, simply covering the surface with skin is a completely insufficient architectural strategy. If cartilage or internal lining is missing, load-bearing structural support is absolutely required. Think of this as cartilage grafting to rebuild and reinforce the infrastructure. The vital question a surgeon asks isn't merely, can this surface be covered? It's actually, will this reconstruction remain stable and protect the airway through months of natural tissue contraction?
For larger or deeper defects, staged forehead or cheek-based flaps are utilized. Think of this process as constructing a temporary, connected tissue bridge. We transfer well-vascularized tissue to the nose, deliberately maintaining its connection to the donor blood supply over multiple stages, until a brand new blood supply is established, which leads to a later division procedure. This proves a really vital rule in complex reconstructive craft. Securing reliable, robust tissue is far more important than rushing to finish the project in a single day.
And sometimes you just need to expand the project team when the required build involves major internal lining loss, airway compromise, extensive cartilage framework loss, bone involvement, or the need for general anesthesia or microsurgery. Collaboration with another specialist might absolutely be the most evidence-based path forward.
Section 5. Realistic outcomes and next steps.
Once the architectural work is completed, setting realistic expectations for the maturation of the project is essential because honestly, no surgeon can promise an invisible scar or a guaranteed perfect function. The early appearance is never the final result. In those early weeks, swelling, redness, and graft color variation are totally standard. Over the coming months, flap thickness, firmness, and contour will evolve and settle into place. In fact, studies show that appearance-related satisfaction may continue to improve well through the first year. It's a maturing structural project, and it takes time.
Because every single nasal reconstruction is a totally unique architectural puzzle, having a structured, informed conversation with your treating clinician is paramount. You are a crucial part of this blueprinting process. It's critical to actively discuss these specific questions so you fully understand your wound's unique blueprint. Ask them which nasal subunits and tissue layers are involved. Ask if cartilage support or lining is missing, and whether contraction could distort your nostril or airway. You want to know exactly why a particular toolkit option is being recommended over others for your specific defect, and whether the repair will happen immediately, in stages, or after a planned delay.